We have wonderful lecture in this morning, and so I can skip several topics. And this is a beautiful marker here. The most difficult question is to be or not to be. We take a look at the antifungal strategy from prophylaxis, empirical, preemptive, definitive. We see a lot of, we know too late. Definitive therapy is too late. It's a concern for patient and for physician. However, Professor Chapakati already mentioned the limitation of current diagnosis tool. And the most important, for example, in Taiwan, even galactomannan is not available in many hospitals, even medical center. So what can we do? So it's a very simple answer. Physician will ask, why we just get the prophylaxis? So the rationale is the invasive fungal disease associated with sustainable mobility and mortality, and very difficult to diagnose, even physician, because we take a look. Dr. Tampa has the paper. Take a close look. Not everyone has fever at a diagnosis of proven or probable invasive mold disease. Do you remember that empirical therapy is symptom-driven, but the most important signal is fever? If no fever, it will challenge our knowledge and experience. What is the first symptom? Trigger your awareness and initiate diagnosis and treatment. So, but not everyone has fever. So, it's not just because of limitation of diagnosis tool, it challenges our experience and knowledge base. In addition, we all know that even the best available current agent, the response rate is suboptimal, unsatisfying. In addition, for every proven or probable cases, we use a lot of resource, including the direct cost of the medication or others. And we need to treat for a long time. And we need additional resource to monitor or to monitor the response or the side effect. In addition, because of very poor host condition, we need prolonged therapy, or even recurrence, we need to continue or second prophylaxis. Most important, if you are hematology, you complain a lot just because of infection, so we delay the subsequent chemotherapy, and the prognosis become very poor because the key variable for the long-term outcome is the underlying disease. So, but in recent years, we do have some advance and achievement. We start from the Fluconazole. Fluconazole is the very important message to demonstrate that Fluconazole prophylaxis versus placebo. They do reduce the invasive fungal disease, especially Candida, and improve the outcome, improve the survival. However, during the follow-up, the same institute, they found that there's more and more invasive aspergillosis. So there comes the Fluconazole versus mould-active prophylaxis. For allogeneic stem cell transplant recipient, this approach did have decrease of invasive fungal disease. However, very high proportion of them discontinue or Itraconazole just because of side effect. So all the benefit is limited to subset of patients who tolerate the drug. So to come out another issue, tolerability, compliance. So we come have the Posaconazole. This study is very important. It demonstrated that reduced incidence as well as a better survival. However, for stem cell transplant recipient with GVHD, the incidence of invasive fungal disease decreased, but there's no benefit for the overall survival. How about the Voriconazole? Voriconazole have better bioavailability comparing to Posaconazole suspension. All the study is based on Posaconazole oral suspension. If you have experience using the Posaconazole, you knew this the limitation of bioavailability. And the Voriconazole demonstrated better, so come with the Voriconazole. This study is terminated earlier just because ethical concern, so the p-value is not significant. But this is important, demonstrate that at present time, although the data support the prophylaxis, but in reality, including our hospital, we did not use prophylaxis routinely for patients with AML receiving induction chemotherapy until several years ago. And this demonstrates the significance of difference without prophylaxis. When compared the Itraconazole for allogeneic stem cell transplant recipient, this study is a multi-center randomized control trial across 12 countries. And unfortunately, they demonstrate the better success of prophylaxis. But it is very tricky because it uses a composite endpoint, including survival, no breakthrough invasive fungal disease, as well as not discontinuation of study drug. So you can see the benefit related to better compliance of Voriconazole compared to Itraconazole. However, there's no benefit for survival. So this is some experts criticize this. Then this is another very important study, very large scale, well designed, very comprehensive, very ambitious. This is a randomized double-blind trial across many transplant centers. They enrolled adult patients and a pediatric patient. There comes the problem because hematology, they said the different outcome between adult patient and pediatrician. So this study did not demonstrate significant difference regarding to invasive fungal disease or survival. However, the post-hoc analysis identified AML as a very important independent factor associated with invasive fungal disease. So if we narrow down to high-risk patient, that is AML, Voriconazole show reduce invasive fungal disease, improve fungal-free survival, although there's no difference in overall survival. No matter the outcome, but this study demonstrates very, very important message. If you decide not to give mould-active prophylaxis comparing to Fluconazole, if you integrate very comprehensive diagnosis in addition to therapeutic intervention, you may not compromise patient outcome. This is the information you interpret in the opposite side. So, because limitation of all these even randomized control trial, so they come up another way of how to utilize this information. This is systemic meta-analysis, incorporate 20 randomized control trial. They show reduce the risk of invasive aspergillosis, comparing mould-active with Fluconazole, and reduce the risk of invasive fungal infection-related morbidity. However, no difference in overall mortality. However, this study showed that they are associated with increased risk of adverse event leading to antifungal discontinuation. As I mentioned, Itraconazole issue. This is another way to approach. This is systemic review, and all important randomized control trials compared Fluconazole or Itraconazole. how we compare Posaconazole versus Voriconazole. So this is a study method we call mistreatment comparison. The conclusion is this mould-active agent compared with Fluconazole prophylaxis in high-risk patients. They show that reduce the risk of proven or probable invasive fungal infection, including Itraconazole, Posa, and Vori. But regarding IA, the only Posa and Vori had this benefit. In addition, this, in the reality, this is large-scale observation study in China demonstrate antifungal prophylaxis, either primary prophylaxis or secondary prophylaxis, comparing to non-prophylaxis cohort, they show reduce the invasive fungal disease in patients with allogeneic stem cell transplant recipient. In this study, because in China they use a lot of Itraconazole, and this study found that it's a very interesting finding that the use of Itraconazole is an independent factor associated with invasive fungal infection in primary prophylaxis group, in addition to age, type of transplantation, and the nutrition status. They show the benefit to improve the overall survival after transplantation. They come up another study for patients in neutropenic status. They systematically reviewed 25 studies and showed that antifungal prophylaxis is more effective than no prophylaxis in reducing invasive fungal disease. Because in Taiwan, we do a lot of debate for this category. We all accept high risk in stem cell transplant recipient before engraftment, and we also accept the GVHD, but we have a lot of concern because it means that more patients will receive prophylaxis. And this study showed that the risk after Vori or Posa was lower than after Fluconazole or Itraconazole tablet. In addition, Posa was also found to be more effective than no prophylaxis in reducing all-cause mortality. This is the only one had demonstrated this outcome difference. So we have a lot of debate even between ID physician or even between hematologists. It is an easy way to say I give the patient prophylaxis to reduce the risk. However, there's more and more studies demonstrate the resistance, the toxicity, the cost, and the challenge of management breakthrough infection. We do know every antifungal agent has to do some drug-drug interaction or direct toxicity. So if you consider give the prophylaxis, please, if necessary, consult your pharmacist colleague for advice. We are very cross-talk between ID, hematology, and our clinical pharmacist. A citation list study, just a recent published from Japan, to answer two questions. Does use of antifungal emerges resistant in immunocompromised host? Is it difficult to manage this kind of breakthrough? Is it common for this kind of patient had occurred breakthrough infection while receive prophylaxis? In Japan, they use a lot of micafungin. You can see that. But this data show that it's very infrequent to develop breakthrough candidemia. The etiology is not surprise. The most common is paraphernalia, then followed by glabrata. And the glabrata from study from United States or France, they did concern the glabrata which was resistant to echinocandin. The most common use is micafungin. The majority remain susceptible to micafungin. And this study showed that the host factor is the major driver of the breakthrough instead of resistance. They did show that the steroid use and the prolonged severe neutropenia were independent factors associated with breast-wing candidemia. So host remain the key. However, we still concern the resistance. Then another issue is the cost. Who pay the bill if insurance not covered or others? Physician always concerned, I would like to have best outcome for my patient, but if in Taiwan, if national insurance not covered, not approved, then what can we do? This is based on many data we put on this table. The ideal is we can better survival and not cost much. This is so-called dominant. But the reality is not so wonderful. The majority is better outcome, but cost more. But if the data is in this quarter, it makes more cost effective. You can see this is for AML, MDS receiving induction chemotherapy. This is the bone marrow transplant recipient with severe GVHD. They compare Posa versus others. You can see the different conditions from different countries. The conclusion is prophylaxis does not always cost more. However, prophylaxis for high-risk population does not always do better. We need disease-specific or country-specific cost-effective analysis in order to make your own decision. So I reviewed several costs. I have no idea. This is very difficult for me to understand how to conduct this kind of study, although we try to cooperate. This is a network meta-analysis. Based on Singapore, Dr. Tan is one of the authors. So if any question, just ask Dr. Tan. This is based on Singapore healthcare the data. The conclusion is all triazole except itraconazole capsule were effective in reducing invasive fungal disease. Among them, Posaconazole was more effective in reducing invasive fungal disease and all-cause death than was Fluconazole and Itraconazole. And you can see that except Itraconazole did not have better, but consider the ISHAM. Itraconazole is dominant, and Voriconazole was dominated by Posaconazole. So based on this study, they prefer Posaconazole. If you are the insurance or you are the to make decision. But come out another study and just publish. They do the decision analysis model structure based on Spanish National Health System data. They come to another conclusion. I skipped the detail because the genetic itraconazole is a least cost. It's very straightforward. And Posa spends more. But the conclusion is different from Singapore perspective. As primary antifungal prophylaxis in allogeneic stem cell transplant recipient, Voriconazole was more likely to be cost-effective than Posaconazole regarding cost per additional invasive fungal disease and additional deaths avoided. It is very complicated to go to the detail, but it is very important. If we use the same database from clinical trial, but you put on the different costs based on different health insurance system from different countries, you might come out to be different conclusion. Another concern is from ID physician. Because we limited target of current antifungal agent, if you put on the antifungal in prophylaxis, what can we do to management the breakthrough infection? So we need to more narrow down. As Dr. Tan already mentioned, and give a very wonderful background information. Among hematology malignancy, AML is the high risk. However, even the incident of invasive fungal infection is vary even by the same disease. Among them, neutropenia, prolonged profound neutropenia, remain the most important risk factor. Regarding the GVHD, it's a most important risk factor among stem cell recipients. The key is the steroid, the dose of the steroid. In addition, prior invasive aspergillosis is a risk factor, but very likely underestimated, especially for referral center. If you did not pay much attention to review all the history from another hospital, you might, and another hospital not aggressively to diagnose invasive aspergillosis. It turned out to be, once you give another chemotherapy or stem cell transplantation, recurrence rate is very high, and especially for patients with multiple risk factors, demonstrated here. However, study had demonstrated second prophylaxis with Voriconazole reduce the risk for recurrence. Nowadays, more and more aggressive for our hematologists. There's more different kind of intervention or transplants or immunosuppression agent. We take an example using the anti-CD52 monoclonal antibody. We publish this data. You can see a mushroom in this young gentleman. The college age, the size as big as a mushroom. The blood culture, the swab culture here, the skin culture, all grew fusarium. So we're very aggressive, give you the combination therapy, use a high dose ambisome plus voriconazole. This young gentleman overcome this crisis. However, risk can vary widely even with the same hematology underlying disease, just because the chemotherapy regimen, whether they receive transplantation, they receive antifungal prophylaxis. So how to make your decision? I always ask my hematology, before you consult my opinion, please you assess the risk before consultation. Don't challenge us. It's so complicated, from primary disease, from underlying other comorbidity, other factor, or even environment factor, but we take a lot of effort. We working together to review the history. From Australia group, they emphasize that if the hospital undergoing construction in a hospital or in a community, you should be very careful, take this risk. If necessary, you will be more aggressive to give prophylaxis because the risk of beyond the evaluation for patient host factor alone. This is the environment factor. They come up, it is very complicated, so how to integrate the multifactorial into the risk assessment. This just published. They establish and validate in the same hospital. This risk prediction score that demonstrate that the proportion of proven or probable invasive mold disease, this difference, and with or without prophylaxis using Posaconazole, there's significant difference in the proportion of proven or probable invasive mold disease. They incorporate 4 risk factors. More important, Posaconazole prophylaxis, based on this risk factor, they change the incident and a better survival. So, you maybe have idea whether we should give the prophylaxis. But what agent? As I mentioned, based on cost and the efficacy, cost-effectiveness analysis. However, you need to pay attention, not just population decision-making based on the population. You should take close look for patient variable. So you consider which agent, you consider the efficacy. In addition, you need to consider the patient factor, to consider whether there's drug-drug interaction, the toxicity based on the host factor. You need to familiar with which formulation of antifungal agent. Because Itraconazole, the tablet, is different from solution. Posaconazole, there's a oral suspension versus tablet. The bioavailability are different. In addition, you should be very careful to evaluate patient compliance. If the patient's poor compliance, it's useless. And for security, because patients think I'm take the prophylaxis, physicians think this patient has take prophylaxis, so it is very unlikely to develop invasive fungal infection. This is a very dangerous situation. In addition, cost, who pay the bill? So we take 5 years to get a consensus in Taiwan. From a lot of debate, we discuss and come out to the consensus. So based on our FWG project, we did a lot of survey. And in Asia country, we did follow IDSA guideline, some follow European guideline, and China and Taiwan had national guideline. But take a close look. Whether you implement antifungal prophylaxis, it varies by country. Taiwan did have the high proportion have prophylaxis for AML patient and stem cell transplant recipient, just because we take 5 years. Since we second version of national guideline, published in revised in 2009, our hematology are not happy because we did not achieve the final consensus regarding the selection of antifungal strategy, empirical versus preemptive. And shall we more aggressive antifungal prophylaxis? So we take 5 years to make consensus, and we just publish. You can Google and open access. And we decide to split the guideline into 2 parts. This is a conventional one. We're just talking about how to treat the patient with proven or probable invasive fungal disease. But we decide to initiate this proposed guideline, just focus on how to select the antifungal strategy and how to select which agent. From evidence to guideline, we adapt the IDSA guideline, not just focus on quality of evidence. We should balance between benefit and harm. We should consider the disease burden as well as with the resource and cost. And also strongly suggest to give this risk-adapted and a dynamic antifungal strategy. This is not original from us. It is from NUSI's review. It's a wonderful idea. We strongly suggest before chemotherapy, you need to decide the risk and decide you don't need the antifungal prophylaxis or use the anti-candida or anti-mold prophylaxis. And the subsequent will be different because when you use the anti-mold-active prophylaxis, will compromise all the microbiology diagnosis yield. So you need to balance. So it's not just to decide prophylaxis or not. You need to incorporate all the components. How to decide, how to select antifungal strategy. We think there are several factors you should decide before you decide prophylaxis, empirical, preemptive, and target therapy. Before you give the chemotherapy, The most important is population-based, based on local epidemiology, the incident and the individual risk of invasive fungal disease, as I mentioned. In addition, take into account of the diagnosis, the modality, the accessibility, availability, turnaround time is very important. The company said that this is a rapid test. However, in your hospital, the mycology lab perform this kind of test once per week. So the turnaround time is 7 days, not just 1 hour. In addition, you should take individual consideration for this patient. He lives in the mountainside. Once he has fever, it's very difficult to access to health care. However, for patients just live nearby, you can access to and call for help anytime. It will be different decision. In addition, you need to consider the therapeutic factor, either compliance, bioavailability, direct toxicity, or drug-drug interaction. This is individual consideration. In addition, from the society perspective, from the insurance, for example, in Taiwan, is National Health Insurance System. We take into consideration the cost effectiveness. So we come out to the, before consider the pharmacological intervention, every strategy to reduce the risk, including the environment control, patient education, is the fundamental. In addition, be aware the use of antifungal will reduce the yield of GM tests and others, and increase the uncertainty to managing the breakthrough infection. So we just demonstrate 3 high risk. Can you see any very different from international guideline when we choose the primary versus alternative agent? Can you see any difference here? This is the strong recommendation versus weak. This is a high quality or low quality evidence. Can you see something unique in Taiwan's guideline? Here, Posaconazole, despite the high quality and the strong recommend based on IDSA and other international guidelines, our society decided to put into alternative instead of primary because we think AML MDS patients receive induction chemotherapy, not necessary universal prophylaxis. You should be highly select. So we decide to put into alternative instead of primary agent. It's quite different from others. Others are similar to international. But another unique feature is we put on and encourage you to use the nystatin suspension. There's no good evidence. It's a very old drug, but it remains, although limited evidence, to support its positive benefit. Regarding the secondary prophylaxis, there's no good evidence, but strongly recommend, and the choice of agent depends on the etiology prior infection. The duration will continue until myelin reconstitution or immune reconstitution. In this guideline, we also introduce the concept of health economy. This is the first guideline in Taiwan incorporate this concept in order to settle down the controversy, concern between hospital, between subspecialty. These data are based on Taiwan epidemiology. In order to make the consensus, we do this study, and it has been published because the incidence are relatively high. So come out the conclusion that Taiwan accept AML should give the prophylaxis, but should be individualized risk assessment in each hospital or individual to decide whether give prophylaxis, but insurance will cover this expense. So in conclusion, debates remain regarding the universal prophylaxis due to resistant toxicity costs and others. Primary agent to be cost-effective in highly select patient population. Selection of agents, strategy, or agent should be individualized. Thank you for your attention.